Hi, everybody. My name is Adam Jones-Delcourt, and I'm one of the ER physicians that's going to be doing some of your acute care training while you're doing your residency with us. And this is the first of a couple of different modules that are going to cover some topics in acute care and emergency medicine. The idea with these talks is to give you some of the prerequisite knowledge so that when we go in and do our simulation, we can just spend all of our time playing with a mannequin and we won't have to do as much teaching. Before we start, I just wanted to put up this slide and just express a big thanks to Dr. Gillick and the Department of Family Medicine at Queen's University. For a number of years, they've been running the Nightmares course, which is a really highly rated program that they've offered to their family medicine residents. And we've been given permission to steal some of their material so that we can try and duplicate some of their success. So what we're doing with our simulation program really wouldn't have been possible without a lot of the help from them. So a big thank you to those guys. This first talk is more a review of the basics, and I think is going to cover stuff that you probably learned in med school. But by the end of this module, you should be able to explain the physiology of different types of shock and recognize the clinical manifestations of shock. So very basically, shock is what happens when tissues just don't get enough blood flow. If perfusion is reduced, the cells don't get enough oxygen, they don't get enough nutrients, they take some damage, and eventually they start to die. Now, the problem with this is that you can't measure tissue perfusion directly. You'll never know exactly what's happening at the cells and exactly how much oxygen they're getting. So we rely on surrogate measurements to tell us a little bit about what's going on. And the easiest surrogate that you'll be aware of is going to be blood pressure. And blood pressure is an important one to point out just because it's the one that's universally available. You'll have this in the recess room, you'll have it up on the wards, you'll have it in the back of an ambulance, and you'll always be able to get some sort of number to tell you what's going on. But you shouldn't have to rely on blood pressure to get a sense that shock might be going on. You should be able to pick up clinical signs of this as well. And the clinical signs that shock might be occurring are things like altered level of consciousness, tachycardia, weak pulses in their extremities, dry membranes inside their mouth, maybe cold extremities in their hands and feet, or if they've got a catheter in, you can see whether they're producing urine or not. And these sorts of things should actually be part of your general circulatory assessment. So when you're thinking ABCs, right, you walk into the room to assess the airway, you see if they're alert and talking to you, maybe you look inside their mouth. To assess their breathing, you use their stethoscope and listen to their chest. And to assess their circulation, you look at the blood pressure, but you also look for this sort of stuff, right? Feel distal pulses, look for dry membranes, are they pale, that sort of stuff. Just because the blood pressure is normal doesn't rule out shock. A patient could still be in a compensated state where their tissue perfusion is reduced, but there's a bunch of physiologic mechanisms going on just to try and maintain that blood pressure. And this phenomena of compensated shock is why ER doctors always freak out about sending somebody home who still has a little bit of tachycardia. We always wonder, is that just like a viral syndrome or a bit of pain or a bit of anxiety? Or is that a patient that's going to suddenly lose their blood pressure as soon as they step out into the parking lot? So when we talk about different types of shock, I'm going to be using this figure to help explain a little bit about what's going on. So just to orient you to the picture, obviously the heart-shaped thing at the top is supposed to be your heart. The red pipe that's coming out of it is supposed to represent your arterial outflow. The blue blob at the bottom is supposed to be a capillary bed, so you can imagine your organ of choice, like a kidney or the liver or something like that. And the blue pipe going back to the heart is supposed to represent the venous inflow. So blood pressure is made up of two different factors, so cardiac output and systemic vascular resistance. And cardiac output very simply just refers to how much blood actually comes out of the heart when it's beating and doing its thing. Systemic vascular resistance is a little bit different. It refers to how big is the space that the blood is supposed to fill, or more accurately, how much pressure is in that space. So if the vascular space is really big and really dilated, that pressure is going to be really low. And if the vascular space is really clamped down, it's going to be like a really high pressure system. Now, this does get a bit more complicated because cardiac output further breaks down into heart rate and stroke volume. And of those two, I think heart rate is pretty straightforward, right? So if when the heart beats, it puts out a certain amount of blood, it could just beat faster and it should put out more blood as a mechanism to compensate if cardiac output was ever reduced. Stroke volume depends on a couple of different factors. So the first one is contractility, which just refers to how strongly does the heart beat. So if the heart needs to put out more blood, instead of beating faster, it could just beat stronger, and that should increase the volume as well. Preload is the other factor that stroke volume depends on, which basically refers to how much blood did you put in the heart to fill it. And that comes back to the Frank-Starling mechanism that you probably learned about in med school. So if I put lots and lots and lots of fluid in the heart and I really stretch out all those cardiomyocytes, the next beat should be stronger than if the heart was not as full and the cardiomyocytes were not as stretched out. The third factor is afterload, which comes back to that systemic vascular resistance again. So afterload just refers to how much pressure is the heart pushing against to get blood out. So if the vascular space is really dilated and the pressure is really low, afterload is going to be really low because there's not going to be much pressure that the heart has to push against. On the other hand, if the vascular system is really clamped down, you can imagine the heart is going to have a harder time sort of pushing against that and getting more blood flow going. Now, all of these things sort of come together to make up blood pressure, but unfortunately, blood pressure doesn't really tell you which part of this system is dysfunctional. So that's going to be your job to figure out in terms of just recognizing the shock syndrome that might be happening in front of you. There are 4 different types of shock that we'll talk about here: hypovolemic shock, distributive shock, cardiogenic shock, and obstructive shock, and we'll go through each one next. Hypovolemic shock is the first one, and in this form of shock, basically the problem is that the tank is empty. We tend to think of this as a preload problem, so if there's just not enough filling going into the heart, that's going to have consequences for contractility via that Frank-Starling mechanism that we just talked about. And if there's not enough blood going in, there's not going to be enough blood going out, so you're going to end up with tissue hypoperfusion. Hypovolemic shock breaks down into 2 major categories. So the first is hemorrhagic, where what you've lost is mostly blood. And the second is non-hemorrhagic, where what you've lost is just fluid rather than blood. And usually you can pick up signs of this on physical exam. So most people who are dry are going to have dry mucous membranes. They might have reduced skin turgor if you look for that sort of thing. And maybe they'll be pale because they've lost some blood and they're anemic. On history, things usually line up too, so they often complain of vomiting or diarrhea for a mechanism for fluid loss, or sometimes there's been an accident or some kind of injury or trauma that suggests that there could be some bleeding somewhere. Now, there are a couple of other processes that can lead to fluid loss that you need to be aware of that sometimes kind of sneak under the radar. One of those processes is third spacing. So this would be in the case of like pancreatitis, where the fluid loss isn't obvious. It's not vomiting, it's not diarrhea, it's just inflammation and some fluid that's been lost in the retroperitoneal space. You can sometimes see that in ascites or in CHF, where somebody looks overloaded just because they've got edema somewhere, but maybe they're intravascularly dry. The fluid's just not in the blood. A similar process is occult bleeding. So remember that you don't necessarily have to have a history of trauma to have bleeding somewhere. You could have a ruptured AAA, or you could have an ectopic pregnancy, and there's tons of blood with that, but it's not going to be bright red blood that you see on exam. And we also need to keep in mind concepts like insensate losses or poor intake, remembering that a lot of these people who are sick with other mechanisms like vomiting and diarrhea and that sort of stuff will still be losing fluids or not keeping up with fluids in other ways. So as an example, if you have like a pneumonia or a sepsis and you're breathing really fast, you can lose fluid just through your breath like that, and that's an insensate loss. If you've been vomiting, yeah, you're losing fluid because you're barfing, but if you're not replacing fluid, you're not drinking anything, well, you're not keeping up with it. So the poor intake also contributes to the hypovolemia. And insensate losses and poor intake really can be applied to almost anybody that comes through the door who's pretty sick. So you got to keep those in mind too. Now, obviously, if the tank is empty, you're going to treat this by filling up the tank. So usually we just treat this with IV fluids. The only exception to that would be if there's bleeding. So if you think the patient is losing blood, the best way to treat this is to replace it with blood transfusions. And we'll talk about why that is later on. Distributive shock has a different type of mechanism completely. So in this case, the vascular space has just lost all of its tone. And you can kind of think of this as though like the pipes are really floppy and really relaxed. So in this type of shock, you have the same volume of fluid and blood, but because the tone is reduced, the space is really dilated and it's just much bigger than it was before. So the same volume in a bigger space leads to almost like a relative fluid deficit. And then you get tissue hyperperfusion because there's just not enough circulating around. There are a couple of classic forms of distributive shock that you'll see. Sepsis is probably the most common example of that, where an infection leads to inflammation, which leads to this sort of vascular dilation. And usually you can pick up on sepsis because the patient might be febrile, or some people say they have warm extremities instead of cold extremities. And the giveaway is usually that there's symptoms associated with a source infection, like there's dysuria or there's a cough or something like that. Anaphylaxis is the other classic example, and usually you're tipped off to this because somebody will tell you that they've been exposed to an allergen. Now, there's a first time for everything, right? So somebody might not have a history of exposure that gives you that clue. So sometimes you're looking for a rash like urticaria, or you think of it in shortness of breath or some swelling or something like that. Neurogenic shock is another really classic example, which always occurs in the context of spinal cord trauma. So if you sever a section of your spinal cord, you'll lose vascular tone distal to that point. And the giveaway is usually trauma, and usually pretty significant trauma, or it's signs of a neurologic injury, so paresthesias or some sort of focal weakness. Remember, too, with distributive shock, you can also get this with just general inflammation. So it doesn't always have to be an infection that causes that. You could get that with burns or with pancreatitis, or maybe you've just had like a really big surgery, like a cardiac surgery or an aortic repair or something like that. You get enough cytokines sort of floating around, and you'll get enough edema and swelling that you will sometimes lose some of your vascular tone that way. The treatment for distributive shock is with fluids to fill up that extra space, and then vasopressors to try and increase the vascular tone and bring it back to what it used to be. In cardiogenic shock, the problem is essentially that the pump is broken. So instead of beating in its usual organized way, the heart is doing something that it's just not supposed to be doing, and there isn't as much outflow going forward. So that means that tissues aren't getting enough blood, and that's where your shock comes from. And you'll also sometimes see symptoms of venous congestion that go along with this, because if the blood's not going forward, it kind of backwashes into the lungs and into the peripheral circulation. And if you're thinking this sounds a lot like heart failure, that's because it basically is. Heart failure is sort of like a mild version of cardiogenic shock, and you tend to see the same cluster of symptoms. So patients with cardiogenic shock might complain of shortness of breath. They might hear crackles when you listen to their lungs. You might see edema peripherally. If you remember to look at JVPs, you'll sometimes see elevated neck veins. And there's two major mechanisms through which you can get cardiogenic shock. The first is just a weak or a sick heart. So an example of that might be a ventricle that's had like a big MI. It just doesn't beat and just doesn't push blood flow as well as it did before the infarct. You could also see this with severe valve disease, like severe aortic stenosis or like a sudden aortic regurgitation or something like that, where blood just isn't able to get out of the heart because it's dysfunctional in that sense. The other big category is the one you learned about in ACLS. So you can get cardiogenic shock from arrhythmias. If you're bradycardic, you could be too slow to just push enough blood out to tissues. And if you're tachycardic, you could just be too fast to allow the heart to go into a normal diastole and fill. ACLS taught you that if you can fix an arrhythmia, you should do that, and that's the main way that you're going to manage cardiogenic shock. Otherwise, what you're going to do is try treating with fluids, but very gently, because these people are very easy to put into pulmonary edema. And if that doesn't work, you're going to use vasopressors to try and increase the heart's contractility and get a little bit more forward flow. Obstructive shock is the last form of shock that we'll talk about, and in this scenario, there's just a blockage in the pipe somewhere. So an example of that might be like a massive PE just sitting in your venous circulation. So if there's a blockage in that, when blood circulates around, it's not going to be able to make its way all the way back to the heart. And obviously, if there's no blood filling the heart, you're not going to have a whole lot coming out of the heart, and tissues are going to start to die because they're not getting any perfusion there. Now, there's another mechanism through which you can get obstructive shock, and in this scenario, there's some kind of external pressure that's squishing the heart. So this would be like in the case of tamponade, where there's some extra fluid in the pericardial space, or maybe like a tension pneumothorax, where there's a bunch of air in the pleural space, and pressures are just really high. In this circumstance, the right side of the heart, the low pressure system, really starts to fail first. So the right atrium and the right ventricle just start getting really squished down, so not as much fluid is going through. And you can imagine this is almost exactly the same mechanism, right? It's almost like I put an obstruction like right in there to prevent flow going past it. Now, in these cases and in other cases of obstructive shock, sometimes you can gain a little bit of ground by increasing their preload. So if you give some of these people a little bit of bolus of fluid, sometimes you can just sort of increase the pressure in that low pressure system and just sort of squish past that bit of obstruction, and you can improve perfusion that way. Virtually every form of obstructive shock comes on with some combination of chest pain, shortness of breath, and distended neck veins. We talked about pneumothorax as an example of that, where you might see some tracheal deviation, or if you listen to their chest, you might have decreased air entry on one side. Tamponade is another example that we talked about, where classically you see chest pain, distended neck veins, and muffled heart sounds. But I think most people are probably using an ultrasound to make this diagnosis. And pulmonary embolism was the first example that we gave, which I think is actually one of the more stressful ones to make a diagnosis around, because often it's just chest pain, shortness of breath, and shock. So it's pretty non-specific. And unless you've got other risk factors like, estrogenic medicines or like a history of prior DVT or something like that to tip you off, it can be a tricky one to sort out. ACLS taught you that if you can fix the obstruction, you should do that, right? So if you think this is a pneumothorax, don't do anything else, just put in a chest tube and fix it right now. But sometimes this is sort of easier said than done. A chest tube might be easy, but tamponade requires a pericardiocentesis, and you've probably never done that before. Pulmonary embolism, you might push TPA to get their blood pressure back, but if you haven't had a confirmatory test, that can be sort of a risky decision to make. So we often end up temporizing these people with fluids and sometimes with vasopressors just to see if we can bring up their blood pressure until we can get them to some sort of definitive management. So to summarize, we talked about 4 different kinds of shock. Hypovolemic shock, where the tank is empty. Distributive shock, where the pipes are floppy. Cardiogenic shock, where the pump is broken. And obstructive shock, where the pipes are blocked. In hypovolemic shock, the tank is empty, so you got to fill the tank. Use fluids or blood to do that. If you've got distributive shock, you're going to use fluids to fill sort of the extra space, and then you're going to use vasopressors to shrink that space down to what it should be or what it used to be. If the pump is broken and there's some way to fix the pump, like shocking to treat an arrhythmia, you should do that. But otherwise, you're going to use fluids very carefully, making sure you don't overload the person. And you're going to use some vasopressors that help increase contractility. If the pipes are blocked, you got to alleviate the obstruction, but until you're able to do that, you're going to temporize the situation with fluids or with some vasopressors. And if you think mechanistically, then this tank, pipes, pump analogy probably works really well for you. If you're an acronyms person, the old shock acronym works just as well as anything else. In this, the S stands for sepsis, the H stands for hypovolemia, the O stands for obstruction, the C for cardiogenic, and the K, of course, for anaphylaxis, because it's a dumb acronym, but it still works. I think you should try and keep one of these sort of modes in your head somehow, because these scenarios are always stressful. The patient's always sick, things have to happen fast, and the situation often changes really rapidly. So it's easy to get distracted and to miss stuff. And if you've got some kind of checklist that you can kind of run through in your head, I think you're going to be less likely to miss things. Now, looking at all of this on one page, one thing I would highlight is that very basically, the treatment is almost always some combination of fluids and vasopressors. So when things are really complicated and you're having a hard time figuring out what's going on, just remember, fundamentally, there's like 2 big things that you got to do to fix someone's blood pressure. And you can almost always fall back on those because they're almost always going to be at least some part of the treatment plan. So that's it. And in our next talk, we're going to be talking more about vasopressors. So we'll give you a little bit more information on what those are and how they work very soon.